Be unmuted.
Good morning to the board and those watching. Thank you for your time this morning. We are actually in an interesting situation. We have neither our chair or
Right from the top then.
Good morning to the board. Those watching. Thank you for joining us today. We have a situation where neither our chair or board chair are present. So we are going to ask if it's to the liking of the board for Commissioner Curtis to chair our meeting for this meeting. We plan on the meeting to have voting options. So that's certainly that's to the board's liking. That's how we do it.
All right, good morning. We'll go ahead and call the Board of Health meeting to order. First item on our agenda is to go into the executive session to discuss with legal counsel matters relating to agency enforcement actions and potential litigation, which is allowed under RCW 4230.1. I'm going to look to staff and legal counsel for estimated time. What you would like to
Start with 15, and if we need to come back longer than that, we can always step back in and do that. So
If the board is okay, we'll go ahead and move into executive session for 15 minutes and then we'll come back. All right, thank you.
Tell me what.
No.
Well, good morning. We're planning to extend the executive session for another 15 minutes. So we anticipate reconvening at 9:06. Just want to let everyone know. Thank you.
You're muted now.
Morning again. The executive session has been extended for another 15 minutes, so we'll reconvene at 9:21. Thank you. Yes, good morning. The board has asked for an additional things in executive session, so we plan to reconvene at 9:06.
Unmuted? Perfect. All right, we will reconvene the Yakima Health District Board meeting at 9:36. As you know, we entered into executive session. There was no action taken in executive session. So we will move forward in our agenda. Next item on our agenda, item 3 is introductions of guests and staff, and we'll start with Ryan.
Okay, we do have one guest from the public.
Hello, my name is Santiago Choma, reporter with the Yakima Herald.
We have 2 new staff members. I'll have Sean and Chase introduce their new staff.
Yeah. Oh, sorry. Go ahead, Sean. Okay, thanks. I'd like to introduce Fiona Gumbar. She's our newest environmental health specialist. She started this week and want to give a quick intro.
Hi, everyone. I'm Fiona. I'm a recent graduate from the University of Washington, the Bachelor's of Science in Environmental Health and Occupational Health Sciences, and I'm on the EH team.
Happy to have you. Thank you.
I'd like to introduce our new accountant, April Holmes. We're really excited to have her on board. She started last week.
Hi, I'm April. So I am the new accountant. I came from the casino where I was their lead accountant, and I graduated from Heritage University.
Right on. Happy to have you. That it? All right, we'll move to item 4 with public comment. Ryan?
And there were no public comments that were submitted. I don't know if we have anyone from, okay, so we have no public comment.
Okay, we'll move to item number 5, which is our consent agenda. Board members were provided the meeting minutes as well as an overview of the payment of accounts payable. Does the board wish to move forward with the consent agenda? If so, I'll need a motion. Motion to approve. Is there a second? Second. Any further discussion? All in favor to approve the consent agenda, please say aye.
Aye.
Any opposed, nay? All right, the consent agenda has been approved. We will move to item number 6, which is our Yakima Health District Spotlight featuring the West Nile virus surveillance, and we'll turn to Sean.
Okay, thank you, everybody. Today, we're going to be talking about West Nile virus surveillance and our mosquito trapping program here at the Yakima Health District. So West Nile virus is a viral infection. It is the leading cause of mosquito-borne disease in the U.S. And we know that we have it here in Yakima County. So it is a concern of ours to look for that. Even though most infections are asymptomatic, there is a vulnerable population of older folks, compromised adults, at greater risk of severe infection. And people who do suffer symptoms, they tend to be severe, leading to a lot of hospitalizations. So it's one of those things that doesn't happen very often, but it's something that we take very seriously, because when someone does fall ill from West Nile virus, it tends to be a pretty serious disease. And it is a notifiable condition to the health district. So we do get positive cases in the county. We are notified when that happens. Next slide, please. So the way the transmission cycle works for West Nile virus is it starts in birds as a reservoir host. Mosquitoes, bite the bird and bite other birds, and more birds become reservoir hosts, which passes it to more mosquitoes. And mosquitoes also like to feed on mammals, humans, horses, dogs, cats. So humans and horses are seem to be the greatest affected by West Nile virus. Next slide, please. So in Washington, West Nile virus was first detected in 2002, originating again from a bird. The first human infection was reported back in 2006. And since then, we've had 127 cases in humans for West Nile virus in Washington. More locally in Yakima County, we had a horse test positive back in 2005. It's the first instance of West Nile virus in the county. And since then, we've had 30 human cases to date, with our last case being back in 2021. So again, it doesn't seem like a lot of cases, but people who suffer from West Nile virus typically have a pretty severe illness.
Sean, any insight into why 30 or 25% of the cases in Washington State are in Yakima County?
I don't know enough about why 25% would be in Yakima County outside of just the prevalence of the the mosquito population we have here with, stagnant bodies of water and their ability to thrive here.
There aren't really a lot of cases over on the west side for West Nile virus. It's mostly on the eastern side for whatever reason.
Mosquito populations.
Next slide, please. So there are things we can do to prevent West Nile virus. There is no vaccination for humans, but effective ways to protect yourself ultimately is not to get bit by mosquitoes. So use of insect repellents, prefer EPA certified insect repellents. They're more effective, safer. Wear adequate clothing, long sleeves, long pants. With the great technology we have in outdoor clothing these days, they make the lightweight summer shirts where the mosquito season is most prevalent. They're bug proof, can't bite through them. So there are options out there to avoid being bitten by mosquitoes. And one of the biggest things you can do is remove any standing or stagnant water from your property, where you work, where you frequent, or avoid areas with stagnant water. The mosquitoes need standing water bodies to reproduce. Next slide, please. So there is a mosquito control effort across the state and here locally. There's only so much that can be done, but as far as controlling the population itself, there is pesticide spraying for killing the larvae and for killing adults to help keep the population in check. Again, removing standing water, another way to halt or slow down the reproductive process for mosquitoes. But there's also surveillance, which is trapping and testing mosquitoes for different illnesses that can be transmitted to animals and humans. Those studies are being conducted by the State Department of Health, and we can use that data to respond to that data and educate the community about ways to protect themselves and what areas we're seeing potential for illness. Next slide, please. We do have two local mosquito control districts, one through Yakima County, primarily covering the Upper Valley, fairly populated areas of Upper County. However, it's a large county, and there are coverage gaps that exist, especially between Upper County and Lower County, where Benton County Mosquito Control District does conduct work in Yakima County and the Granby Mountain areas. So we do have that Sunnyside to Union Gap that does not currently have much coverage for any mosquito surveillance or testing at all. Next slide, please. So the Yakima Health District secured funding through the State Department of Health to conduct mosquito trapping, to send those specimens into the state lab for testing for West Nile virus for the 2023 mosquito trapping season, which is from June until September. So we just recently started our trapping efforts last week and started shipping those specimens over to Shoreline at the state lab. The funding does support staff time spent in this program, the cost of supplies and the shipping costs. So it's no additional cost to the health district itself. The additional time needed to conduct or operate this program, which is working out to be about 5-6 hours a week at this point. The purpose of this is really to monitor the mosquito population in an area that doesn't have any monitoring currently, and to gather data on the prevalence of West Nile virus, in that Union Gap to Sunnyside area. Next slide, please. So for this season, as this is our startup season, we've selected 2 sites, one in the Zilla area, right along the I-82 interstate at a couple ponds that are really popular for recreating. It's fish and wildlife land. These ponds are stocked with catchable trout, so a lot of people frequent the area, and it's an area with a lot of standing water. So really high mosquito population area. So that was one site that was selected. Another site is a fish and wildlife land in the Sunnyside area that does have bodies of water in the area. Recreating happens on public access. So we thought it would be believe it would be a good site for us to conduct that. Next slide, please. So the procedure that we're using is encephalitis vector surveillance traps, or EVST for short. I learned how to pronounce that word overnight. So, so it's set up essentially with a bucket of dry ice, a fan, and a mesh net. So it's built to draw in the mosquitoes and then, force them into a mesh bag where they are trapped. It's placed roughly 5 to 6 feet off the ground in a tree, so around that level where mosquitoes tend to pester us, right around our heads or arms. Pretty common in the air we find them. And then we set the traps overnight, and then we are out there first thing in the morning the next day to collect the specimens so they don't spoil throughout the heat of the day. Next slide, please. So we take our specimens, we put them in a cooler with ice and moist paper towels and a little bit of airflow to keep them as fresh and preserved as possible. And we ship them directly to the public health lab, or we utilize our courier service if they're available for testing. And then we are able to look at the results on a listserv for a vector monitoring profile online that we can see how many of our mosquitoes or what percentage of the specimens we're sending in have tested positive for West Nile virus, if any. We haven't received any results as of yet, because we just got this program started. Next slide, please. So how this ties into our strategic goal, this is a new program. We do have a mandated service in our vector-borne disease program, or vector control. And primarily that deals with rabies surveillance, collecting specimens from animals that bite people where we cannot rule rabies out. However, this is an expansion of this program with the funding we received from the state to conduct vector-borne disease surveillance beyond just rabies. So it is strengthening our mandated services, and it also I'll get to the next point later. Anyway, our next goal, developing a network of community partners invested in improving public health. We have a longstanding partnership with the State Department of Health. So it was relatively seamless and painless to undertake this program, to receive funding for it, to receive the supplies. As that partnership is already at work here, and we're assisting the state in addressing a known problem, especially in our county, but allowing the state to get more data, get more knowledge about the prevalence of West Nile virus in Washington. Also, we've worked with Fish and Wildlife in the past, accessing Fish and Wildlife lands, working with them on land development. So it was really simple to secure access permits for us to be able to access the land legally, and we were easily granted that permission to set up our equipment on their property. So it made selecting the two trapping sites we have very, very simple and very easy to implement. We'll increase the effectiveness and efficiency of district services. We're expanding our services and our presence in the realm of public health. West Nile virus is, not common, but it is a problem. And if we can assist our state partners in identifying how common it is or how prevalent it is every year to year, because it does change. We want to do that, and we want to be able to communicate and educate our community members on if there is West Nile virus present in any given season in a specific area. Also, the potential to be that catalyst in building public health and building a program, and then potentially assisting our local mosquito control districts by identifying, yes, this work is needed beyond the current scope, and assisting their capabilities and potentially expanding, the area in which they work, and being the subject matter experts on, mosquito surveillance. Maybe they can recognize that there to and that this work is needed and assist in the expansion of this program. So, that concludes the spotlight. Is there any questions?
Thank you, Sean. Are there any questions
I have a
from the board?
Recently, malaria cases have been found in Florida and Texas. I'm just wondering, diseases are tested, you send them in for West Nile virus, are they testing for anything else?
I believe for this program, it is just West Nile virus, as that's what's known to be present in Yakima County. I don't know what would trigger the state to want to test beyond that. But potentially, I can come about in the future. I just haven't heard of testing beyond West Nile virus yet.
There's different species of mosquitoes, and so some that carry malaria or like the Zika virus, they don't live up in the Pacific Northwest. So we don't tend to see locally acquired cases. And I know Dr. Barr is going to present in his report on malaria specifically. So.
Actually, I looked that up for the sake of time.
What's that?
I left the malaria part out, sorry.
Oh,
Just to
well,
address
there
that question, the Anopheles mosquito is the one that carries malaria, and it's been limited by climate. So as the southern part of the country gets warmer and warmer, average warmth goes up, the spread of the mosquitoes. The malaria outbreaks that used to occur before screens were invented, and mostly across the southern United States, when screens got in the south, the malaria outbreak diminished. So you have to have actively infected people in the location to have locally acquired. This isn't the first time it's happened. There have been other outbreaks related to camping in a small area and somebody having malaria from some other part of the world coming back and then the mosquito biting multiple people. So it's possible it will become endemic again in the southern part of the United States, but may not ever catch on as much as it did before the screens and before antimalarial drugs. So we've had a couple cases here, people coming back from sub-Saharan Africa who did not take their prophylaxis.
Dr. Bard and Sean, maybe, what is the symptoms? What happens when human contact or
It's high fevers,
just high fevers?
muscle pain. And the way that it's suspected is like some of those symptoms are that severe. They might hopefully and usually do ask, where you been? And if they say coming back from, then exposure is possible. Then you can do a rapid test called a Binax, and you'll get the results of the malaria organism. It's not the organism itself, but the antibodies to it. And then you can proceed with treatment.
What about West Nile? What symptoms? Same symptoms for West Nile?
No, West Nile is central nervous system symptoms. So they might have, a patient might have a flaccid arm, for example. And you have to think about it, because in an elderly person, you might think about stroke first. So it leads to a lumbar puncture if they have signs of meningitis, like headache, stiff neck. And there's a battery of tests that can be sent off for a central nervous system pathogen test. And that's one of the viruses that are on that big panel. So it's not hard to diagnose if you suspect it.
Is that person that has contact, are they contagious for the rest of their life, or does it go through a cycle where mosquito?
They're not contagious at all. Okay. So it's basically an avian virus. And often the surveillance for dead birds often will be the increased suspicion of transmission.
Any other questions from the board? Thank you, Sean. That's a good presentation. We'll move forward with item number 6, item number 7, which is our agency reports. We'll go ahead and start with our executive director, Andre.
Thank you, Commissioner Curtis, and good morning again to the board. Thank you for your patience as we were in executive session. Sean mentioned our work with surveillance as part of a catalyst model, and so I wanted to use that as a great segue for what we're going to introduce to you. Pre-COVID, we worked with the Kresge Foundation on what we could do to work on innovation in our county, and we were chosen and we developed something called the Rural Health Innovation Catalyst, which is a fancy way of saying we want to do things. But the bottom line is that we wanted to find ways to work with our partners on issues that were prevalent in our community. focus on how serious the issue was and could it be addressed, and then find the partnerships, the initiatives and the funding to make a change. Again, action-oriented work on behalf of the community, not just because we receive grants, not just because we're a public agency, but because there's work to be done and we have the privilege to do it. And so we've been talking to the board now about the concern around opioids, fentanyl overdoses, the concerns that we've had. We discussed the realities that there needs to be more to do in the community. There's a great deal of conversation around naloxone and wanting to get that out into the community. All we had discussed in previous months, the opportunity to potentially purchase a building, and we chose not to do that. One of the reasons was that we would be spending a great deal of money on the purchase of a building before we even began the initiative to benefit from the purchase of it. So we took a very different direction, which allowed us to have more money at the end of a fiscal cycle. And so one of the things that we are able to do, and I'm pleased to announce that we can purchase 1,500 boxes of naloxone, which come with 2 doses per box, and we're buying 1,500 of those. This is in anticipation of changes that will be coming. Correct me if I'm wrong, Melissa, but the idea that naloxone in this state will become over the counter soon. We have discussed with the board the realities that there are organizations that are interested in having naloxone on hand, that there's private companies, restaurants, social service agencies that wish to have it. They have access and opportunity to care for people. And there's also the opportunity for us to expand what we already do. Which is with people one-on-one about the use of naloxone and then give them naloxone that they have. Right, Melissa? So we're very pleased to purchase this naloxone, but we want this to be more than the distribution of 1,500 doses. We want this to be a model for how you blanket a community with life-saving measures. We want to use this as an opportunity to not only give something to people that's frankly expensive, but a small price to pay to save a life. But we also want to be able to communicate our commitment as an agency to the well-being of our constituency. We want people at all levels of our community to have access to it. And we want to avoid the very real circumstance, which is unprecedented in my personal life and career, that you can take one pill and literally potentially die. It's that serious. So we're not talking about someone taking some illicit drugs and then becoming addicted immediately. We're talking about life or death. And it also has been something that I think through tragedy has brought our community together. So we're very pleased to share with you that we have these. We don't have them on hand essentially yet, and we're going to build this initiative, but it's more than just distribution. It's public awareness, it's communication, it's commitment, and we want to do it all over Upper Valley, Lower Valley. We want people to have access and understand it. We want people to understand and embrace that their lives matter. And we also want to embrace a relationship with chambers of commerce and private businesses and city halls. We want people to have access to this. So in the event that there's an emergency, it's readily available. So it's more than just the inventory. But I do want to share with you candidly that often in government, you don't have access to funds to purchase things. So you say, I wish I had money so I could buy something to help people. We are doing that now. We're moving quickly on it. It's a coordinated effort. Certainly defer to Ryan and Melissa if you have more to share, Dr. Barb, but we're very excited about it and certainly happy to answer the questions you have.
I'll just add that we are also, I'm working with the coroner and I'm hoping to work with first responders on doing some geocoding so we know where most of these overdoses are happening, so we can do very targeted outreach and provide Narcan to businesses in those areas to ensure that. Some of these businesses, we have people who are using their restrooms and then overdosing in the restroom, and so for those businesses to have the Narcan on hand.
Yes, and some of these businesses are national in scope. It's not that they can't afford to get it, but it's complicated. Sometimes it's difficult to receive. We're trying to really revolutionize the way we get it into the hands of people who then use it. I do want to make a distinction. This is not about giving away products that the health district acquired to individuals without an education. So we're not giving this to businesses who will then distribute it to others. But as an example, if a fast food restaurant has a history of people using drugs on their premises, we want them to have access to these life-saving drugs that they will keep, and in the event that there's an emergency, they use it.
I think you hit that right on the head, Andre, because, I mean, the state has a free program, so any of us can go and get a free Narcan mailed to us. And I went through the program, and there's a nice video you watch to educate yourself. But the gap that I think we have in our community is our business sector. And so getting those resources to the business, making sure it's there and accessible in the event of an emergency and need is very important. So good work.
Thank you. And candidly, I've been in a number of cities where I saw people beginning a process of drug use on private business premises, whether it was around a corner or in a bathroom or in the back of a business or in the parking lot. It's prevalent. It's all over our country. But there are a lot of organizations talking about what they could do. We want to address this. And to Melissa's point, we have an epidemiologist on staff. We have data. We want to track this, and we want to work with our partners and listen to our social service agencies and our schools and our law enforcement partners to determine where the issue is, not in a punitive measure, but to address how we can educate people and prepare for worst case scenarios.
So will you track who has given doses, and then will you track the expiration date, because they do expire pretty quickly? Will you track that and swap out?
Well, we're lucky, actually, if you want to share the expiration.
Yeah, the shelf life is about 3 years for the ones that we purchased. And those are not that long.
Yes.
Do you have Narcan or naloxone? You have nasal or? Yeah, that's what these are as well. But yes, the idea is that we'll have, when they use one, that will create some type of survey when they need a new one. And that survey will then list, did it expire? Did they witness an overdose? Did the person respond to it? That's the idea. So to get a new one, they do the survey, so we have the data.
Yes, and Ms. Dill, I failed to mention, it is the nasal that we purchased, which is easier to use. Intramuscular is less expensive, but I think there are many people who are uncomfortable with needle. So this is a simpler process. But your point is well taken. On our harm reduction site, we ask people to share their awareness of the use of naloxone to save life. But we will ask for something more formal from our partners. And I suspect that they would happily share that information. So we may not distribute all of those doses because we want to have some to replenish. But we also are using this as an example of this catalyst model of determining where the issues are, where the prevalency is, where the concerns lie, because this is a community-wide issue. This is not just a public health issue. This is not a drug use issue. This is a community prevalency issue. And I actually think that if we are able to track information and create an opportunity for people to share, we will hear examples of things that we weren't anticipating about where people access these drugs and where they use it and where the concerns are. And also, we want to make certain that people understand that this is about life saving, and that's, again, a public awareness campaign.
Also not a social class issue.
Absolutely. So from an equity standpoint, we want all businesses that are interested to have access to it. We want to have people from all backgrounds to have access to it. We want people in emergency situations where they may have made choices that are now imperiling their life to have access to something life-saving. And we want people to understand how to use it. So whether or not someone receives the medication from us, a public awareness campaign can allow them to understand how they can access it themselves or use it in that situation. So it's really about a new model of involving the health district in community-wide discussions and initiatives on behalf of the best interests of the community. So we're very pleased about it. Happy to answer any other questions that you may have. Okay. I'd like to wait a little bit to discuss the impact of this purchase and this program on one of our unfinished business items, which is expanding into the Lower Valley. But out of respect for the fact that that's on the agenda, I'd like to wait.
Sounds good.
The other is that we have been looking into other ways to provide Narcan in our community. We've done research on Narcan vending machines. But again, that's an unfinished business issue at the end of our meeting. Under number 8. Narcan vending machines Chief Health Officer. Unless you have other questions, that's my report.
Thank you, Andre. Any questions from the board? We will move forward with our second agency report from Chief Operating Officer Ryan.
Okay, so our after action report for our COVID response will be out. So we sent all the board and sent to the State Department of Health and it'll be public information. We did send out surveys to our internal staff, to all the board members. Thank you for all the board members that responded to that, and also to our community partners. And so this will be a valuable tool as far as seeing what we did well, what improvements we can make. And so that we're excited. It's a 56-page report. It's pretty lengthy and but a lot of good information.
There's going to be no tested.
Right. Also, we continue to see investments through from the state and State Department of Health and Foundation of Public Health Services. One area where the state is focusing on is environmental health. And so they what we need is more of a presence in local health jurisdictions and state policy on being part of state committees to make decisions statewide. We also have locally, we have a lot of issues that are non-fee driven issues such as PFAS, such as nitrates in groundwater and in the Lower Valley with fires and landfills. And so what the state has done is invested in different positions at local health jurisdictions in like management level to help so that would provide to have local health jurisdictions beyond state. And so what we've done is we've created an environmental health manager position, which will be able to focus on the day-to-day operations, managing staff, managing these fee-based programs, and we'll allow our directors to be able to be more part of the policy making, be on committees and deal with a lot of the other issues that take a lot of his time, and then we can also make sure that we're focusing on staff too. So we are in advertising for an environmental health manager position start by the end of the week. And then we'll do interviews that will close on July 16th, and then we'll do interviews. And by the next meeting or the meeting after that, we'll be. Yep.
Yes, I just wanted to share clarification. The funding is being generated from the state legislature. It's coming directly to us. It's now our funding. It's not a state position within the health district. So the state is not dictating the work or the parameters of the position. It's just the reality that many jurisdictions in the state have working directors in environmental health, which keeps those directors from doing anything other than day-to-day. Something like a Guama situation or a PFAS situation. There's not enough time in the day to address both. So,
Do you know if the funding from the state is a one-time or if this is continuous?
no, it's continuous.
Okay.
And we actually, I'm on the Foundational Public Health Steering Committee, and one of the things that we tried to do was to allow for flexibility built into that funding. So if a jurisdiction wanted to hire a new position, they could do so. But if they wanted to use existing staff to work on issues like policy or address issues that are not revenue-based, fee-based, they may do so. So this is trying to marry the reality that environmental health in our state is normally fee-based, which doesn't allow for other supports.
And then also, we are still in incident command system for the response to the subsurface landfill fire at PTG landfill. And so our local emergency response coordinator, Andy Wilson, will give an update on that.
Yeah, so the health district is still in incident command. Tomorrow, Thursday, we're going to have a public meeting at the Department of Ecology from 6 to 7. Focus of the meeting is going to be updating the public on the current situation, the upcoming remediation plan, the evacuation plan, and notification procedures. Also encouraging them to sign up for Alert Yakima. And then on Friday, DPG will start their remediation process.
I have, if there's any questions.
Thank you, Andy. Thank you, Ryan. Any questions from the board? All right, we'll move forward with our health officer, Dr. Barg.
All right, so I want to talk about
four things today: increase in the number of new HIV cases in the county, an outbreak of fungal meningitis. That shows a lot about healthcare infrastructure. Fentanyl case that occurred in Bellevue, speaking about not socioeconomically linked, and the salmonella outbreak that's not only going on here, but many other places in the country. And some of these are actually linked to the change in healthcare availability due to COVID. I'm going to start with the increase in the number of HIV cases. And this is a graph that shows the yearly number of new cases diagnosed in Yakima County. So back in 2017, there was a large bump, but then it was lower until COVID hit and the numbers jumped up again. And in 2023, that's only the first 5 months. We've had 16 cases, and if it goes at the same rate, we're going to end up with 30 or more cases, new cases, which is, this goes back maybe to the early 2000s, late 1990s, where we had that many new cases coming in. So there's some postulates about how this happened, and this is again not unique to Yakima County. This is going on across the country. And because of the public health emergency triggered by COVID, there's decreased access to HIV services among other healthcare services. But they noticed when they were looking at the tests that were performed across certain geographic areas that there was a decreased number. So the patients were not reporting for the tests for many reasons related both to availability of places to go, the safety of going there, and things like the lockdowns and the shelter in place. So there's also a decreased amount of people asking for pre-exposure prophylaxis, which is very effective at preventing transmission of HIV. So the person who's taking that medication won't get HIV if they have intimate relations with somebody that does have HIV that's not on treatment. And another data point that they looked at was the number of prescriptions that were filled for HIV treatment. So all of these suggested that people were not pursuing, treating, or diagnosing HIV to the same level that they had. So other things that happened that contributed to this, there was a closure of non-essential businesses. So non-emergency healthcare venues, for instance, closed down, and there were less places for people to go, even if they wanted to. And then another factor that played a role was increased unemployment due to closure of businesses from the emergency declaration and the loss of medical insurance as a result. These all played in a role. Now, with the tapering of the epidemic, we're seeing the numbers of people accessing healthcare, the number of tests being done, and number of prescriptions going back to pre-endemic levels. What we're seeing here in this year is the tail end of the previous 3 years lack of access. So people are going to be diagnosed with HIV if they're not going because of risk issues, like they recognize that they're in a risk issue, they're going to go when they start feeling sick. And there's a big lag time from 1 to 10 years in acquisition of HIV and presentation with symptoms of HIV. What we're all trying to do now is track down contacts of new cases, and the DOH has a system built in to do that. And everybody that we see in our clinic that's a new case, somebody from DOH comes over and sits down and talks to them that way. So some of the things that people want to get in place, particularly CDC, in case another pandemic occurs and there's another healthcare emergency, is to create HIV testing outside of clinical settings. So this could be a home test like we have for COVID. And I think the home test was a game changer for COVID because many people didn't go to work or didn't go to school if they had a positive test, which really decreased transmission. Same thing with HIV. If you can test yourself at home, then you're going to change your behavior or you're going to seek medical care. And those are two positives. Another proposed change would be expanding the use of pre-exposure prophylaxis. Is a drug called Truvada, which has been on the market for a long time. It's a combination pill. It's one pill once a day, and more than 90% effective at preventing transmission. But right now, you have to go to a physician's office to get the prescription. So they're thinking about creating more telehealth visits specifically for pre-exposure prophylaxis, and also perhaps make it available in pharmacies. So you can go up to the pharmacy, talk to the pharmacist, and ask for that medication, similar to the way Paxlovid was made available for patients who had COVID. So these things are in process. The self-test kit hasn't been approved yet, but they're working on it. So I think those would be game changers. I want to switch gears.
Dr. Barg, if I may, really quick, that chart shows Yakima County cases.
That's correct.
When you look at the data, is it 50% male, female, or are you seeing any trends specifically for who's our infected population that's being exposed?
Yeah, I actually don't have, I mean, it's available. I just don't have it with me.
Dr. Barg, if I may, is it your assumption that with increased testing and increased access that the numbers won't continue to increase?
The idea is to package this whole thing in to get by, I think, 2030, 90% reduction. We're talking about 90. And that's the goal from national standards, CDC.
But I'm also wondering, we were affected as an agency in communicating with our partners who serve communities that were affected by monkeypox. Is there enough communication and awareness about the need for testing, the need for choices to protect themselves, certainly the need to consider pre-exposure prophylaxis?
Yeah, I don't think this has been rolled out. These are things here with analysis of what happened over the last 3 years. In the CDC documents, these are the things that are being proposed. So I think these will roll out over the next couple of years. And a lot of that's to provider education and patient education at HIV clinics. So that's what happened with monkeypox. The patients were in clinics, they heard information, they took it out in the community, and it was really effective at shutting things down. So I think education of patients and providers really helps.
It's something that we're looking at too with the Department of Health and their epidemiologist is looking at which clinics are doing STI testing, but not doing HIV or syphilis, which we know we have a syphilis outbreak. So doing targeted messaging to those providers to test for testing for STIs as well.
Yes, if I may too, this is an indication of what we do all the time in public health, but public health often lags so that you see an issue, there's a reaction, there's a problem, and then there's a rollout, but it's slow. And what we're trying to do is expedite it to avoid the maladies of increased cases.
This is a very good example of public health infrastructure being able to be in place before there's a problem and then quickly engage with changes in education. Switch gears to the.
Do we see an interest, Dr. Barg, in people receiving this information, patients receiving this information, where there is availability of prophylaxis, that people are actually utilizing it?
There's actually quite a bit of underutilization of it. There's barriers to getting it. A lot of it has to do with social stigma and stuff. So we also have been limited by our HIV clinic not being able to take care of PrEP patients while we were funded by Ryan White. But as far as things in town goes, I think that probably most of the PrEP is being given clinics like farm workers and neighborhood health. And I don't know about the private practices as much because we're not interfacing with them. And our HIV clinic isn't interfacing much except when they make referral for a patient. But the DOH is in there on every patient. We're trying to do contact traces. So,
Very
yeah.
few primary care providers are prescribing it. We were contracted with Planned Parenthood and Neighborhood Health. So when we have someone come in STI testing, we screen them to see if they're at risk and recommend PrEP. Those are the two places we refer to, but there's really primary care. It's just not, I think it's the lack of education or just knowing how to prescribe it and what labs are needed follow up.
And maybe that's the role of the health district to help fill that gap.
And if I may too, that people often, I think in provider settings, think of who their clients are and then predetermine the kinds of services or discussions or histories. And that is also an awareness that we have to work on.
Actually, something to consider, which it wouldn't be the easiest thing to do, but possibly doable would be a PrEP clinic. run out of a organization that has a larger clinic. So there's not instantaneous stigma associated with going to the PrEP clinic. Remember, these are pediatric patients that don't have HIV, but just at risk for getting HIV. And that would take some work, but I think it is doable. And the many different providers that are in town that have very different clinics, and there's no centralization. So something to think about as the year goes. Any other questions regarding HIV issues?
Is
Okay.
it okay if I ask a question?
Yeah, sure.
For the at-home tests, are those gonna be free of charge, or like kind of like how you could order like a pack of COVID tests once a month per household? Is it something like that, or?
It's not been FDA approved yet,
Okay.
so they're still working on the mechanism of it. So wouldn't even know, but
Okay.
chances are they've made it available. They'd have to be cheap to be useful.
I wouldn't anticipate that they're free. And the cost barrier is often why people who have limited means often become ill because they can't afford the.
Yeah, if you think of them. as you go on. So in the news, there were 2 students in Bellevue that overdosed. And they were both found in an apartment complex unconscious. First responders were called and came and administered Narcan immediately. One of the kids woke up and is doing okay. The other kid did not regain consciousness and end up in the ICU on a ventilator with some end organ damage. When they looked into their behaviors and how they might have acquired it, it looks like it was from vaping. Vaping, there's a little cartridge that goes into the electric pen that has oil in it. And drugs are put in there like nicotine, for example. In this case, fentanyl, methamphetamine can be put in there. So people can add things in they want, or they can buy cartridges and have no idea what's in them and stick it in the vaping can and yell it. And fentanyl goes through the lungs just as easy as it goes through the stomach. So this is not the only case. There have been several previous small incidences with vaping pens that have been reported to the DEA. And it's an example of the lethality of fentanyl, that you take so little, a couple puffs off a vape device, and it can lead to an overdose. So getting these Narcan kits around like defibrillators, in places where emergencies can happen, but not distributed to the general public, but available to the general public is what's going to help shut this fentanyl down. And I don't know if our government's going to be successful in getting the raw materials to make fentanyl decrease that's being manufactured in China and then distributed to countries all over the world who then assemble the components of the fentanyl and sell it, distribute and sell it. And that's going to, getting the raw materials under control is probably the best way to get the fentanyl under control, but politics right now will not let that happen.
Are those vaping cases, do they know enough to know if they were intentionally, if the fentanyl was intentionally put in?
Yeah, that I don't know. One could suspect that happened, but also I think it's probably possible it's unknown. That they bought some cartridges from a friend and they were adulterated. So I think you can also add whatever you want to a cartridge. So unknown or purposeful. Okay. We'll move on to fungal meningitis. So there's a kind of a thing that people like to do. We call it medical tourism. So you want to get something done, plastic surgery procedure, hernia repair, and it costs thousands of dollars in the United States, but you can go to another country, even Western Europe, and get the same thing done for a fraction of the cost. For instance, if you want to have a total hip replacement, the same technology in Europe, or maybe half the price of that. So one of these medical tourism issues involved surgeries that were done in 2 clinics in Matamoros, Mexico. So people came down from the US to have things done. The procedures involved epidural anesthesia. So a a needle is used to access the epidural space, which anesthesiologists do on a routine basis. And then a drug is administered that will numb the nerves. And then whatever below that level where they put the needle in, that area will be numb and surgery can be done in that area without pain. And probably nobody remembers, but in 2011, there was a big outbreak of fungal meningitis that was caused by epidural, well, not epidural only, but steroid injections into the spinal area. The steroid material that was injected was contaminated with banana leaf fungus, which was very, very hard to treat. And a lot of people died from that. And it happened in clinics that were pretty much set up to do those procedures. So once they discovered that the material contained fungus, they got rid of that material. They in fact closed down whole factories that were making it to make it safe. This is a similar thing where these cases occur between January 2023 and May 2023. And one of the interesting things is the Mexico Ministry of Health and the CDC collaborated this and very quickly uncovered the cases and the cause. So the material that they were injecting to numb up the tissues was contaminated with a fungus called Fusarium solani. They diagnosed this because samples of the spinal fluid that were taken from the patients that were exposed or had symptoms of meningitis were sent to labs, and the DNA analysis showed the Fusarium consistent DNA. One of the labs that did it was University of Washington Molecular Diagnostics Lab, which I use all the time. It's an excellent lab. So this particular thing is tragic for sure. There's another reason not to engage in medical tourism, but it's also a very good example of how the public health infrastructure and collaboration between similar agencies in different countries worked to solve this in a very quick and effective way. There's actually been 16 suspected cases from all the people that were interviewed. Some were symptomatic, some weren't. There just was a basis of exposure. 9 of these cases were confirmed, and out of those 9 confirmed cases, 6 have died. Pretty bad average, 40% death rate. So this is a bad infection. The earlier you get treatment, there are antifungal agents that treat it. The earlier you get it in, the better the survival, but some of these can go 3 months or so before it becomes symptomatic, which is why they did tracing of all patients. And from our standpoint, what we would normally do is put a provider alert out to say, hey, if you had a patient, went to Mexico, got these procedures done, let's get them into the system and get tested. Any questions on medical tourism?
Dr. Barg, you say that notice, so we are sending out that notice? Is that what you're
I
saying?
don't think we have yet.
So we plan to.
Well, that's
If you'd
what we
like to,
normally
we
do.
will. Yeah.
No, that's what we normally do. So I don't know how, I suspect that there's a good chance we do have some medical tourism going to Mexico. So, one of the things that a lot of hospital-based physicians don't like is when somebody will go to another area and have something really complicated, like go to Phoenix to get a heart transplant, then they get sick. And then you say, oh, let's send them to UW. They don't really like that. And we had a case like this. We had a case exactly like that. The Phoenix hospital wouldn't take them back. And finally, we got UW to agree to take them. But they had a serious complication of heart transplant. So stay in town. I mean, medical tourism is in Seattle.
Yeah.
Medical tourism in some other country. All right. Any questions on that? All right.
Medical tourism is more common than most people might think. It's extremely common. I see clinic patients several times a month that tell me they've gone to wherever and had a procedure done, so it's not rare. Just a footnote onto your previous report. As a parent, I mean, I think we have to all have uncomfortable conversations with our children regarding exposure to fentanyl and drugs like fentanyl and the use of naloxone. And even if you think, well, my kids aren't doing drugs, whatever that means, it's more common than I think. And having those conversations could potentially save a life, as in Bellevue's case. Early access to naloxone saves lives without question. And pray to God that my children never need it. But I do have those conversations with my kids, and I think that everybody should, whether or not you think your kids are doing drugs, maybe they save their friend, maybe they save a stranger, it's important. So public service comment, parent service comment, I guess.
I think kids might not consider vaping drug dangerous.
Correct. Which it is.
Absolutely.
Yes.
Well, even I've seen kids get in the ICU with nicotine overdose. And they also know how to take certain drugs to block nicotine testing. So if you go to the lab and you get tested for nicotine, they know what to take so that it doesn't show up on the test. All right, we'll move on to increase in salmonella infections. Now, we have a new outbreak going on, but it's not new to have an outbreak. There have been many, many outbreaks of salmonella over the years. And I've been here 25 years. We probably had 6 or 7 different outbreaks related to a whole variety of things. So some of the outbreaks are related to animal contact. So everybody probably heard of the little turtles that people get as gifts carrying salmonella. There's been a lot of food substances, papayas, peanut butter, raw tomatoes eaten in restaurants, raw turkey, dry dog food, and the latest is home harvested chicken eggs. You may remember to Safeway and a dozen chicken eggs, a dozen eggs were like, $12 or something, organic was even more. Now, of course, prices come down, but as a result of the pandemic driving supply down and prices up, people said, well, I'm just gonna buy some chickens. And a lot of people have, and the ones that haven't been eaten by coyotes are producing a lot of eggs. And actually, they're quite good. The homemade ones the yolks are a lot nicer looking, they're more yellow, they taste better. But the problem is that many chickens have salmonella in their gastrointestinal tract. And as the eggs are being produced, the contents of the gastrointestinal tract coats the outside of the egg. And as a result, people are getting salmonella more commonly. Sometimes it's very low symptomatic, sometimes it's high fevers and bloody diarrhea, depends on the patient. So people have been looking at this very closely, and it turns out that there are ways to handle the eggs which large producers of eggs employ all the time. But people who raise chickens in their backyard or small outfits, maybe they have 100 chickens, something like that, they may not be aware of these. So there's CDC has recommendations that are easily available. And if we put out a provider alert on this, we can include this. It's really easy. Basically, it's wash your hands after handling the eggs. Be safe about the backyard flocks. Don't be affectionate with your chickens. Don't touch them if you can avoid it. Just throw food in there. So it's definitely a recommendation. Supervise the kids around the flocks. Don't let them hug the chickens either. In fact, I had a case where a chicken bit a guy and the chicken died. but the patient also got an infection related to the flora of the chicken's beak. So, but yeah, don't mess with your chickens. Handle eggs safely. So collect the eggs often. So don't let them sit in the chicken waste. So get them out every morning, get out there and get them. If they're cracked, throw them away because the salmonella can enter the inside of the egg through the cracks. And they don't recommend handling the egg as far as cleaning with water. If you clean it with water, then the salmonella can use the water and get into the egg. So you brush the egg off, you wipe it off, you brush it off. And then as soon as you got things ready, get them in the refrigerator because they are contaminated with salmonella. The salmonella won't grow well in the refrigerator, so keep the numbers down. And if you want to get these eggs, and use them, don't make hollandaise sauce out of them. Cook them. So you don't want soft yolks. You want cooked yolks. They have to get up to about 160 degrees, which pretty much is going to be a hard-boiled egg. So I am not putting raw eggs in my smoothies anymore. And there are typical symptoms that if you were raising chickens at home and you got sick, you need to recognize when you might be sick. So it's diarrhea with fever greater than 102, bloody diarrhea, vomiting so intense that you can't keep fluids down, and signs of dehydration, like decreased urine output, dry mouth and dry throat, and feeling dizzy when you stand up. So those recommendations are available, and I think we should publicize them. You know, while people, it's becoming more and more popular to have backyard poultry. So get the word out, and more to the public than the providers. I think we do both. Really do. This is all just topical right now, just coming out.
Is there more common in coop-based chickens versus free-range chickens? Is there any difference?
No, I don't think so. I didn't see that specifically mentioned. You would think if they were all cooped up, but most people have their backyard chickens have coops where there might be 2 or 3 chickens in it, not like 20, and they're ranging around the backyard. They're not ranging around it. Bigger producers will have, when they say free range chicken on the boxes, they're out and on much, you know, maybe an acre or something. I think the free range is just a way of not getting them all stuck together. But it's, you can go in a supermarket and test chicken for barbecue, and some of them are going to have salmonella in there, which is why you want to make sure you have properly cooked barbecue. That's a well-known. Campylobacter and salmonella travel together, and they're both can be found in undercooked chicken and other poultry products. That's it for me.
All right, any questions from the board? Just to do a quick time check, I know on our agenda it said till 10:30, so is the board comfortable moving to 11:30, or do we need to conclude at 11? Just getting a check-in real quick. We do have quite a few items left on our agenda. 11:30, okay?
20 minutes, 10 minutes to give me enough time to get there.
Okay, well, I have an 11 o'clock and I'm going to move that out to 11:30. So we'll try to conclude by 11:20, 11:15. Okay, all right, let's move on to our next agency report, financial report with Chase.
All right, good morning, everyone. In the interest of time, I'm going to move along quickly. If you have any questions, please stop me, please interrupt me. My report starts on page 9 if you want to follow along in our board packet. But at first, I'd like to give a quick update on audit that we're experiencing. Entrance interview last week, Don was able to make it, as long as with Andre and myself. It's an entrance interview. We laid out the expectations and what the engagement is going to look like. Hoping to have the exit interview at the end of July, so hopefully we'll be wrapping up here. We're going okay so far, not quite ready to declare victory, but steady as she goes. So getting into the financial report for the month of May, we had of 133,000 excess revenue, bringing our total excess revenue for the year to our allocated revenue was 4.1 million and our actual is closer to 4.6. Our allocated expenditures at 4.2 and actual is closer to 3.7 million. Any questions on the summary? Again, I'm moving quickly. If there's anything you would like to discuss, please let me know. Moving into the income statement. Looking at revenue pieces. Unanticipated but much needed rate increase for that program. And so we're starting to see that come through, as well as our investment income generated over $600,000 this year, which is another surprise for me. Getting down into the expenses, the only real thing to highlight would be the provider services DD, really close to the bottom. Again, that's just the expense following the revenue. Any questions? Second page of the income statement. Again, not a lot to note here. Just having some overages in our small tools and equipment during repair and maintenance. I'm sorry, I got off on a thing, and that has a lot to do with the paint on the wall. You guys probably have noticed our outside is nicer and cleaner as well as the inside. Well, Commissioner Ron Anderson would be very happy right now. Any questions on the income statement? Next page, our program list. FPHS heavy, we have a lot of FPH activities. What Andre was speaking to earlier. I really have nothing to highlight here unless there's any questions. Moving into the next page, again, not a lot to highlight. It's a, EH is moving along in the summer. You can see we have some uptick in solid waste activities that you all know about. And those, a lot of those programs are just quarterly. We'll see an uptick at the end of June. Any questions on programs? Okay, next page, moving into COVID. Again, just kind of that spigot has kind of turned into a trip. It was a fire hose. Now it's just a little bit. Any questions? And last but not least is our cash flow. A slight decrease in cash, which was expected. We'll see an uptick. I don't think in June, it'll probably be July when we see the uptick. And that'll be our flexible dollars, and we'll have another round of it. Any questions on the financial report? Apologize for the speed there. I went through. We're done.
Thank you, Chase. Any questions from the board? All right, we'll move next to our disease control update with Melissa.
I was gonna give an update on salmonella, but Dr. Bart did a great job. I'll just add that there's, out of this current outbreak with the backyard poultry, nationwide, there's 410 known cases, 18 in Washington State, and then last month I reported we had 2, we now have 3 in Yakima County related to this outbreak. And then also we're seeing an increase in our animal bites, pretty common this time of year. We've actually sent off quite a few specimens. We sent off 1 bat and 2 dog specimens in the last couple of weeks to test for rabies. So a lot of animal bites going on. So
Are we seeing any trending in reptile pets? I know that salmonella common in that group, but it was getting popular for a while. And then are we seeing reptile-based salmonella versus chicken-based salmonella?
no, right now it's the backyard, the chicken one, yeah, backyard chicken.
Hopefully your reptiles don't get to your chickens.
Raccoons will, and then rabies will go.
That's it for me. We'll talk more on the harm reduction expansion during that part of the agenda.
Thank you, Melissa. Any questions from the board? All right, we will move forward. Next is our environmental health update with Sean.
Good morning, everybody. So got some stuff to talk about in our solid waste program today. As you know, both of our limited purpose landfills received their permit renewal decision from the health district yesterday afternoon. So both as of now, they still have a few days to submit documents and plans and get things done. But as of July 1, they've been notified that their permit renewal is been denied. So we're looking at a cease in operations potentially for our, as of right now, it's happening, but they still have a few days until July 5th. But looking at a cease of operations for both of our privately owned limited purpose landfills in Yakima County, starting later this week. So I just want to stress that we don't make these decisions lightly. We don't end goal, and it's still not the goal to keep them permanently closed down or anything like that. We're still planning on working with them collaboratively and working on getting their permitting documents in order and getting their operations updated and assist where we can and some of the other permits they need to obtain to gain compliance with the WAC that governs their operations, and which is WAC 173-350. So we're going to continue to work with them and go through that process. I want to stress that we've been working with these facilities for a long time on these issues, and there were goals set for these facilities and notifications given, and simply put, they're at their deadline. So that's why we took the action we did, because the goal is to be compliant, health and safety and safety. So kind of a quick update for a really big event that's occurring, but I'm want to be able to answer any questions you all might have.
John, from the public's standpoint, the capacity for access to landfills and refuse deposit places. Is that being affected in Yakima County based on any decisions that are?
Yeah, and that's a great question. These two facilities, primary waste streams are from out of county waste. However, there is a small percentage of their waste does come from in county, from some industry professionals, contractors, construction, landscaping. And we have coordinated with Yakima County to, on the interim, be able to accept some of those wastes from in-county waste streams. The companies that bring waste from out of county will have to, obviously have to find other resources, but we do have our in-county waste streams. We do have resources for that.
Thank you, Sean. Any other questions from the board? All right, we will move next with our public health partnerships with Lillian.
Yes, and actually, that's why I'm covering a lot of things around the lot zone and communications and, you know, the discussions that we'll have along vending machines. So I won't do as good a job, but we really, I started that.
Okay, thank you. All right, well, now we will move on to item number 8 on our agenda, which is unfinished business. The first item is the harm reduction expansion into the Lower Valley. This was a continued conversation from last month, so we'll turn it over to Melissa to kick this discussion off.
So last month, it was kind of consensus from the board that it, for the approval to go ahead and move forward on harm reduction expansion into the Lower Valley, assuming that we have people in place every week out there who with lived experience or need the services for treatment. So we have identified a place in Toppenish that's a business that is willing to allow us to use their site, but we're also looking at some other options and looking at contracting with these facilities so that we're guaranteed to have a site to go to every week rather than it looks good for a month and then pull out from us. So I'm working on a contract for that. I'm also looking at the communication with Edie as with comprehensive as well as Merit Resources to contract and pay for their staff's salaries and benefits to have a guaranteed person out there every week for that. So we're still in the works on that as well. We're also in communication with the city manager for Toppenish. We had approval from the city council several years ago when we were going to expand and just want to make sure that we're continuing that process and that the city council is aware and looking to see if we would like us to present again or if they also have options for a location for us. So that's the direction we're moving in right now. If there's any questions.
Melissa, do we also have plans for Sunnyside or another large community we have in the Lower Valley?
At this point, we are looking at Toppenish based on where we're seeing a lot of overdose and lack of resources. So we actually were down at their cultural museum last week handing out Narcan to homeless. It was actually pretty successful. So the need is down there. But that's, I don't know if you want to expand on anything, Andre.
Sure, and we're happy to expand and have regular access, but if we're using mobile services, that means that we really have a dedicated plan to make sure that we have operating vehicles working, we have staffing. So we'd like to do that. The other option, as we've discussed, is to have a more permanent location, which again, I like the idea that we can have a location in a number of different cities where we can keep our supplies under lock and key and we can have a clinic room. So I really like that, but I also want to share that we really need to have a commitment from our partners. Now, I want to be candid, as Melissa talked about, we're not looking to do this for free. So if we enter into a contract that pays for some of the space within a clinic, as an example, or a social service agency, I'm more than willing to do that. But I do think we also have to realize that there's a large commitment for staffing. So if we went to a number of different locations within the week, we could be talking about 3 days a week. We have to have staff that can do that, and we have to have backup. Again, wonderful opportunity, and I'm certainly interested in that. And the reality is that Sunnyside is, a place where things happen. So we're open to it.
but the contract that you're working on for the locations in Toppenish, it's a contract in the sense of we will allow the health district to be present, but we're not paying an entity to have our mobile service
I
there.
believe the intention is to pay them, correct, Andre?
Well, there's a number of things. As an example, our location in the city of Yakima was vetted with the city of Yakima, so they were comfortable with us using the location. If that was something that the city of Topish, as an example, was open to, and I can't speak for them, but if they were, that would be fine. But we also ran into a situation, correct me if I'm wrong, Ryan, that we had located a location in Toppenish, and then the person decided that they wanted to sell it. I think it's more beneficial to have a contract in place and commitment so that we don't have a situation where all of a sudden we don't have a location. It's not the kind of thing I think that we can move easily and readily without community participation, because there are some members of the community who will be surprised if that is used quickly. So we just want to have consistency. So whether that comes from the use of a facility because we have a clinic setting, or a municipality decides to partner with us, or we pay an entity to allow us to have access 1 day a week, that's why I brought up the idea. If the board doesn't like the idea of a contract, I'm open to that too, but I was looking to ensure the integrity of the program moving forward.
I guess that I do have concerns with paying to provide a free service to the community in Toppenish. I think there is a win-win with partnering with the city, and I think there's many parcel owners in the city of Toppenish that would welcome it without having to be paid. I do agree, though, that some type of contract or use agreement needs to be in place, but paying to allow this free service, I do have issue with that.
Okay, I hadn't thought about that. I've not entered into an unpaid contract, but I like it.
And then also, I know there was a lot of discussion last month about the provider and lived experience being present. And so we're still working on what that type of arrangement would be. So I would assume that we'll just leave this item on unfinished business until we have everything wrapped up.
Yeah.
Oh, and if I may, Commissioner Curtis, you want to revisit that? That was the point about the contract for the staff person from the department. Share that again.
On paying for the staff's
Sure.
time for comprehensive or merit to ensure that their staff are available for us weekly. Because I mean, supporting these agencies so that we can have somebody out there every week and ensure that there's someone out there.
I guess for me, when we're contracting with it, I think the harm reduction program is most effective as a mobile unit in the front line. I don't think putting it in a clinic somewhere in a traditional setting is going to achieve what we're trying to achieve. And that's not what we're looking to do. We're looking to partner with the clinic for personnel in our mobile unit in the front lines.
Right.
All right, thank you.
Having them out there with us, done in Toppenish or in Yakima.
And eventually Sunnyside, should we get to that point.
Right, but recognizing that salary support is important for our partners to be able to provide the people to facilitate having them there all the time is an important thing to recognize. And if we don't recognize that, we probably won't get full participation from some of our partner agencies.
And I've actually worked with the State Department of Health and been approved to use funds out of a grant for at least through May of next year for individuals who are at risk for COVID who use drugs. We can use those funds for subcontracting, so which we're underusing right now. So it's a win-win.
All right. Did you have more, Melissa?
No.
Well, I just wanted to share also, when we were talking about expansion of harm reduction, our purchase of the 1,500 kits of naloxone is also our commitment to this idea of expanding our presence, our reach, our communication, our commitment throughout the community, but specifically the places within the Lower Valley that have traditionally not had access to those things. So we want to make certain that people, regardless of their background, regardless of their lifestyle, regardless of how much money is in their pocket, they have access to life-saving measures and communication. And it's also, I think, good government in action where we're able to do something quickly and relatively inexpensively without a large footprint. So we're not asking people to come to us to become educated. We're not asking for people to come to us to get something. We are going to them. And I think that that's, again, intent and people feel valued when they're seen. So that's part of our expansion as well.
right, any other questions for Melissa on this item? And we'll carry this over into next month. I would say, Melissa, I do know we also had quite a bit of conversation about data points and like what equals success. Do you think we're at a point to look at some of the data that we've been collecting?
On the overdoses?
No, on the harm reduction. So no, we weren't tracking unique identifiers, right? Is there data there that we can look at next month or?
We are collecting unique identifiers to know how many people we're serving, unique individuals that we're serving each week. So we do have that data. And then I can pull up the information through comprehensive on how many were admitted into services.
I think that would be good to look at. Okay. All right, we'll move forward to item number B, Narcan vending machines to help deter overdose deaths. And as I shared last month, of course, due to time constraint, we really didn't get to dive too deep into this. I'll let Andre kind of bring us up to speed with some of the research, and then really it is an open conversation for the board to provide their thoughts of ways that we can further address the gaps in our community as far as Narcan access.
Thank you.
Andre?
Thank you, Commissioner Curtis. As a reminder, again, we are looking at the potential for purchasing Narcan vending machines that could be placed in different locations within Yakima County to provide access to people who might not have regular access, as we discussed. So in Lillian's absence, I'll attempt to do a good job, but we've done some research on that and found a company that's in Redmond, not Everett, but Redmond, that has vending machines available. We have to see whether they are built and can be provided to us. Again, we have end of contract monies that we need to use to purchase those. That would be done relatively quickly. The idea would be to buy 2 of them and then use it as a pilot program to see where it's most effective. One of the places where you could place it in Yakima County is here at the health district. You have to have access to electricity and internet access. But we also want to have it in a location where it's being observed, because we don't want it abused and we don't want everyone to take all of it. But essentially, there's a process with a QR code where you can get permission to receive one. Part of our thought is to use this not only for the distribution of naloxone, but also to have a way of assessing and tracking who uses it, and even the potential for a short survey so that people receive something for free, but they are asked some questions that allow us to have a better understanding of the people who use it. The other idea is to place it in places like a city hall, and we certainly want to place one in the Lower Valley. It could be at a recovery location, could be in a library. It has to be in a place, I believe, where it won't, again, be vandalized, but the location is up for discussion. The other idea with a pilot program is to try it in different locations and to see where it's most effective. We know from information from other parts of the state and the country that having these located at recovery centers, but also in jails for the public who come in to visit those who are incarcerated and also those who are leaving incarceration, is beneficial as well. So I don't want to assume how this would be beneficial in our county. The idea is to create a pilot program and also to, again, commit to this idea that we're not just giving out information or distributing medication, but we're actually going to track information to find out where hotspots are, where people can share their concerns. And so we have a better understanding of where to place our resources in the future. So we are looking at the purchase of 2 of these. My understanding is that we could use the naloxone that we purchased within that vending machine. And again, you would have to go through a process where you're vetting each person who receives it. And each person gets a unique identifier essentially to receive what's called the QR code so that they can access it and then receive it.
Can you talk a little bit about why we need to go through that process? Because when we're giving up our can at our harm reduction sites, we're not asking for this information, are we?
Survey wise? No, and we don't have to.
We do ask questions out on our harm reduction program. For questions, we ask them, is this your first time receiving? If not, did you witness it? Did you use it for an overdose? Did you give it to somebody else? We do collect that data. This would be for, you would fill out the questionnaire and then you scan a QR code on the machine you'd fill out a few questions, and then it will spit you out a code, and that's the code that you enter to have it kind of wind down and dispense
Gotcha.
out like.
We're
a
not
vending
asking for
machine.
name,
Oh,
date of
no,
birth.
no.
Nothing.
Okay.
Yes,
Thank
that's
you.
true. No unique identifiers, nothing specific to the individual.
And we can create the question, so if it's specific data that we want, like your zip code or.
I think that's actually brilliant to be able to track that data and actually see who are we serving, who's utilizing it, is it effective or is it not a good use of these funds?
And also Chase determined that, if I'm not mistaken, that we can actually purchase the opportunity with this company for them to give us tracking information too. They can show us how it was used, when it was received and so forth. So again, the more assessment and information we have, the better we are in terms of placing this for value. There's nothing worse than investing a great deal of time and energy in something that doesn't reach the people who need it most. And so that's what we're trying to do.
Absolutely, but also we're not recreating the wheel here. We have other entities across the country that have done these Narcan machines.
Yes, and our team spoke with members of what's called an accountable community of health in Grant County area about their use of it, and that's where we gained a lot of our information. So it's being used in Eastern Washington. I can't speak to how effective it's being used. I think the idea, my understanding from our peers and other members of the community, the idea that you have ready access to something, that you have access to something that's not in a clinical setting, that is voluntary, is very helpful. And again, it shows intent, which is we want people to have access to life-saving medication, period. But again, its effectiveness in our community is yet to be determined, which is why we could do this as a pilot program. We could locate it in different places for a number of months to see if it works. We could see how quickly it depletes in terms of inventory. And that's one of the things that also is tracked by this company, as I understand it. So it really is about coming up with a plan. There'll be an investment of time I want to share with you for our staff to assess that information, to stock it. It would be our responsibility and our purchase. But I'm not, I don't feel possessive of this. We just want to make sure. Starting with 2, I think is advisable because we could theoretically have one in the Upper Valley and the Lower Valley. One of the things we're trying to do from an equity platform, reaching all people and where it's located, we're happy to hear your input. We don't want everything to end up either in, the city of Yakima or Toppenish, but we do want it to be most effective. And so if we were to find that it wasn't being used in a certain place, even though we assumed it should be used there, then we'd want to move it.
I think it's trying to, proactively get it into people's hands so they have it available when somebody needs it versus have it out there ready for somebody to be able to get to in the event they or somebody right with them needs it. I work with a couple hospitals that have been awarded grants that purchase vending machines and then chose to put them in their ERs. I don't think it's been successful. If clients that are ODing can get to the ER, they don't need the Narcan.
Yeah.
So I think it depends on the intent.
No, and actually, I'm grateful you brought that up. You would think that having an ER would be a great idea. It's too late at that point. But also, it's interesting that I think it's been located in places as well where you have extended hours of operation, which I also think is beneficial. Because if you think about it, when you say it needs to be observed, that's normally 9 to 5. There are a lot of people who are doing things in the evening where it may occur to them, I need this. And if it's not open, it's not open. So those are the kinds of things that I share with you that we want to explore. It's not just about its purchase and its rapid deployment. It's that we want to make good choices. So there'll be some research in that. And in fairness, we have to get permission from different organizations to allow us.
Well, there's also a certain amount of stigmatization that is still out in the community, should you want to access it and have Narcan, whether it's, oh, that person must have someone in their family that's using drugs, or that person must use drugs. And so having an opportunity for someone to access this resource discreetly, I think is valuable and important. And that's what these vending machines will do.
So does someone need to have a smartphone in order to access the naloxone from these vending machines?
At this point, yes. And one of the reasons is that we can't give our current supply to another entity to then give out to people. that this will change a great deal when naloxone becomes available over the counter. But again, that is an awareness campaign, and that's one of the reasons that we're so committed to it.
Well, the over the counter there's still a cost to that, right? For this resource, we're looking to pilot it as a free resource.
Correct.
Okay.
And that is one of the issues as well. The higher the cost, the less people will have in possession. And that's
The smartphone is essentially just so that you can get the code to have it.
Right,
Or
but what
piano
if someone
too.
doesn't have
Yeah.
a phone?
Well, I agree with you wholeheartedly. Although I am surprised.
Put some information on the front of the vending machine on how to get it, by reaching out to us and coming here to get it.
Absolutely, I'm just exploring the, what if someone needs it, doesn't have a smartphone? What if someone needs it and they want it now? Just the what ifs.
Yes, and we haven't explored. I mean, I would assume it's in English. I would hope that the QR code could also scan in Spanish, but I don't know if that's the case. And we found throughout COVID, there were things that we expected to be translated that weren't. We had partners who expected that to be done, but didn't invest in that. So we may have to create that ourselves. It's not the first time that we've had to spend money on software to create an equity access opportunity. That's something also that we want.
Well, I mean, there's different ways we can go about it, right? Like to Lupita's point, I mean, I would not want there to be any barriers of access to this product. So I could see us having a sign that says, please take this 5-second survey to generate a code to help us better serve you, right? And a disclaimer that says no name or anything is being tracked. And then below it is just a general code that anyone that doesn't have a smartphone can type in and disperse that Narcan. So there could be a win-win for you guys to consider there.
Well, I've seen a number of times, you'll see a sign that says roadwork ahead. And I've been in some communities around the country that say, these are your government dollars at work. We're trying to keep your roads operating. So I apologize for the inconvenience, but we're trying to make it better. That's what we're trying to do here. So I like all this. But again, these systems haven't been built yet. People keep saying, just buy a vending machine and you're good. That's not how it works. So to your point, Edie, it's in the emergency room. If it doesn't get used, it doesn't work. There used to be a stigma with condom machines in restrooms, and now it's pretty normal to see. So we're trying to reach people where there may need access issues. So I'm happy to have this conversation. And we welcome the board's involvement, thoughts, concerns, but also if we haven't thought it through and there's something that you think we could be different, we're happy to do that.
Cost for the 2 vending machines we're looking at.
Oh, yes, thank you. I believe with everything, it's about $9,000 per.
Just under 10 grand.
So
9,000 per machine, depending on the software that we choose.
Yeah, there's some add-ons for asset tracking that we're gonna more than likely purchase that with the vending machine.
So 9,500. The assets are there. In fact, if it's something we can do quickly, the assets will come from a certain contract that's ending, so that's good.
Are the machines fairly durable in terms of vandalism or
Well, we know they're heavy. They're about 900 pounds. I don't think they're vandalism proof.
No,
I don't
that's
think
a
they-
thing, right?
Although I have seen some vending machines recently that had nice metal grates up in
Right.
front, but no, I don't anticipate, which is again why we're been encouraged to have it indoors where it's being watched.
monitored? Yeah. Sure.
The other thing I'll share, one of the hospitals did say it was an education point. They didn't have it set up to dispense with a QR code or anything. It wasn't limited by any means. And they had to educate the older population staff. This isn't nasal spray.
Oh, wow.
Because they found people were.
Yeah, one of
People weren't reading.
Oh, wow.
one of the reasons for the QR code as well is, yes, we also don't want people taking all the inventory.
Yes,
right. Yeah,
That's one of my greatest concerns, is that somebody would say, well, I'll take 25. That's not how public health works. So that's what we're trying to avoid as well. But this will be a learning opportunity for us as well. Again, if we weren't in a crisis as we are in our community, in our country, we could have this conversation over a long period of time. And so making these purchases quickly and trying to create these programs quickly is something that we're committed to do. But there is an element of things not working the way we had anticipated. So I want to share that with you candidly. That's why, again, if we have resources like state resources to use as opposed to local resources, I'd like to do it, but we don't know what success looks like yet. The goal, though, is to do everything we can to save lives.
Absolutely. And I applaud you, Andre, and staff for really taking this by the horns and really finding a solution for us to move forward with. So unless there's any further questions from the board, I would recommend that we'll just leave this on unfinished business for next month. And as there are additional updates or additional guidance that you need from the board, we can chime in there.
Very good. Thank you.
Any other questions? All right, it's been good discussion. So we don't have any new business. I guess if there's nothing else from the board, I would entertain a motion to adjourn. Okay, motion and second. Second. All right, all in favor, please say aye. All right, we are adjourned. Thank you.